We're going to talk about the pulmonary function test. Now, before we deal with all the different pulmonary function tests, we first have to understand the normal pulmonary lung volume. So, this is a pulmonary lung volume diagram, okay? Now, the first of the volumes is referred to as the inspiratory volume. Inspiratory volume is the volume that you're bringing into your lung every time you inhale. For example, if I go like this, okay, how much air I'm bringing into my lung, that is referred as the inspiratory volume. And normal, that is about 500 milliliters, okay? Now, vice versa, the expiratory volume is how much air you're exhaling out of your lungs after a normal exhale. So, okay, and that is also about 500 mLs. Now, if you would go and you would take the inspiratory volume plus the expiratory volume, add them together, that is referred to as the tidal volume. The tidal volume is one inspiratory, one inhale, and one exhale. One inspiratory volume and one expiratory volume, okay? Now, the third of the different lung volumes you need to know is referred to as the FRC. FRC stands for functional residual capacity. Functional residual capacity is basically how much air, what is the amount of air left in my lungs after a normal EV expiratory volume. For example, if I go like this, if I exhale normally, what is the remainder air in my lungs after I take a normal exhale? That is the functional residual capacity. Now, if I would go and I'll take a massive inhale, okay, if I inhale to the maximum, that is referred to as inspiratory capacity, okay? And vice versa, if I would go and exhale maximum, if I go, let's say, okay, that is referred to as forced volume capacity, okay? Now, after a forced volume capacity, after I go, okay, and I exhale as much air as I could, the remainder is referred to as the residual volume, okay? So those are the different volumes. And there's actually one more volume which is referred to as the total lung capacity. Total lung capacity basically is, there's another volume referred to as the vital capacity. Vital capacity is basically how much air that I'm maximum able to exchange within and out of my lungs. So for example, how much air what is the maximum I could bring in my lungs? So for example, it's how much air I could bring into my lungs. So it's going to be inspiratory capacity plus the VC, how much air I could blow out of my lungs. So it's the inspiratory capacity plus the forced volume capacity, and that's going to equal the vital capacity, how much air I could physically move in and out of my lungs, okay? And if I would take the total lung capacity, the total lung capacity is very simple. Total lung capacity is equal to the vital capacity plus the residual volume, okay? Why? Because everything over here is going to equal the total lung capacity. The amount that I can inhale, exhale, which is the vital capacity, plus what I cannot touch, which is the residual volume, okay? So that are the different lung volumes, okay? Now that we understand this, now we can discuss the different pulmonary function tests. Now, first of all, you have to understand the purpose of the pulmonary function test. Okay, we do pulmonary function tests, also known as PFTs, primarily for three reasons. Okay, the first reason why we do PFTs is, number one, if we want to understand the patient's different lung volumes. Also, we want to be able to go and differentiate between the different obstructive versus restrictive diseases. Okay, so that is the first reason why we go and do a pulmonary function test. The second reason why we do pulmonary function test is, let's say I have a person with some type of pulmonary disease. So of course I want to make sure that my treatment modalities are going to be improving my patient, okay? Let's say I give him steroids. So if I'm giving him steroids, if I'm giving him a treatment, I want to make sure my treatment is actually being beneficial to the patient. So I expect to see improvement on the pulmonary function test, okay? So that's the second reason why I would want to do a pulmonary function test to check the treatments, okay? And the third reason why you want to do a pulmonary function test is because, for example, let's say in certain cancers, for lung cancers, which basically causes extensive damage to the lung. So what happens over there is that if the lung is severely injured, studies have shown that you'll have no benefit even doing surgery. The surgery might even kill them. So again, we'll discuss this later about the different parameters what you have to have in order to be a candidate for surgery. But if you are not over a specific number, then you're unable to do surgery. So before every surgery, we're going to have to do a PFT. So the third reason to do the pulmonary function tests are for the different surgeries. Okay. Now, the pulmonary function tests, basically, they are really made up of three different tests. The first one, what we do is we basically, how they work is, they actually work, very different than all the other type of, medical tests we do. Unlike, like, say, an EKG, a CAT scan, an MRI, whatever it is, if you have, let's say, a fibrillation on an EKG, and every patient is going to be a fibrillation, and every patient is going to be life-threatening to the patient. However, if you have, let's say, one value on a PFT, for one patient, that can mean that the patient is going to die the next day. However, for a different patient, that means he could be doing completely healthy. Okay, you see, pulmonary function tests all have to do with a predicted percentage. we basically go, we take the person's age, we take the person's sex, we take the person's height, and a lot of different variables, we plug it into a machine. And machines will give out certain specific predictions of what a patient's normal lung volume should be. Now, when we do the pulmonary function test, of course, we tell the patient to inhale, exhale, all these different tests. And of course, we want that patient's lung volumes to at least match up to at least 80% of what we predicted will come on the pulmonary function test, okay? If, let's say for argument's sake, it's less than 80%, that is known as a abnormal pulmonary function test, and we're going to have to look for additional studies in different diseases of why he has abnormal PFTs, okay? So the first reason why we're going to do pulmonary function test to basically go and we're going to have a look at the different lung volumes, okay? And of course, those lung volumes are supposed to be at least over 80% of what our machine predicted them to be. Okay, so that is the first group of pulmonary function tests. The second group of pulmonary function tests is referred to as the FEV1 over FVC. Okay, in order to understand this, we have to understand that what is referred to as the flow volume graph, loop graph. Okay, so basically on the y-axis, this is going to be our flow. On our x-axis, this is going to be our volume. Okay, normal flow volume loops look something like this. Of course, this is going to be our normal inhale. This is going to be our normal exhale. This is going to be our FR. This is going to be our FRC, and this is going to be our FVC. Okay. Now, normally, of course, when you inhale, obviously volume is going up. Obviously, when you exhale, the volume is going to be going down. Okay. Normally, if you would actually do this in an actual laboratory, and if you do this in the office, a normal official test, the papers that you're going to be getting back are going to be grouped into different boxes of 1 second each, okay? And this is important because normally when we go and we tell a patient to do the FVC, we tell them to expire maximum. What's supposed to happen is that within this first 1 second, we expect 80% of the patient's expiratory maximum air is supposed to go out within that first 1 second, okay? And that is referred to as the FEV1, okay? Forced expiratory volume within the first second, okay? And again, you could try this yourself. You could blow your hardest and you could watch how, the air is the most strongest during that first 1 second. After that first 1 second, then it's going to, coming out very little, okay? And that's what we expect the patient, of course, to be. Now, what's also very important about the flow volume loop is actually this bell-shaped curve over here. And this curve is actually very, very significant. On the left side of the curve, this basically tells us, when we're exhaling, of course, the exhale of air throughout our large airways, okay? And what's important to know about our large airways is that we're able to control the amount of air that comes out in our large airways. For example, if I go, okay, I'm forcing air out of my large airways, okay? So this is fully dependent, okay? However, the right side of this curve, that is actually the air flowing within the small airways. And of course, as we know, air in the small ways is fully independent, okay? Therefore, you could be blowing and huffing and puffing as hard as you want, but you will not touch this small airway. Now, this is extremely important to understand because, like we're going to explain in a second, diseases of the small airways, for example, let's say asthma or COPD, what's going to happen is it's a disease of this curve. This is where you're going to have the pathology if you look at the flow volume loop graphs, okay? That's the second thing you have to understand here, okay? And of course, when we do a FEV1 over FVC ratio, again, if this is the FVC, we just do the FEV1 over FVC, and of course, we plug our values in the machine, and of course, it's supposed to be about an 80% prediction. If the patient has a under 80% prediction, then he's going to have some type of obstruction disease, okay, and which we'll discuss later. Okay, and the third really part of the PFTs is referred to as DLCO. Okay, DLCO is referred to as the diffuse capacity of carbon monoxide. Now, why do we use carbon monoxide? Normally, the three different gases in our body that you have to know is number one, carbon monoxide, carbon dioxide, and oxygen. Okay, carbon monoxide is obviously going to be the most of the soluble gases. Then, of course, carbon dioxide, and then obviously oxygen. Okay, so we use carbon monoxide because it's the most soluble. Now, what basically the DLCO is, we take a tube, obviously, and we tell the patient to inhale this within this carbon monoxide within it. Okay, and we tell him to hold his breath for 10 seconds. Now, normally, carbon monoxide is supposed to go and diffuse through the alveolar membranes, okay? And then after 10 seconds, we tell him to exhale, and we measure the amount of carbon monoxide that he exhaled, okay? Now, if the patient's lungs, the patient's alveoli are functioning properly, what's going to happen is that in healthy alveoli, carbon dioxide would very easily diffuse through them because they're extremely soluble. Therefore, when he blows out, what's going to happen is he's going to have a very low DLCO. So a low DLCO means that a person has healthy alveoli. However, If he, let's say, has emphysema or is alveolar damage, what happens is that the carbon dioxide is unable to diffuse through the alveoli, and therefore what happens is when he blows it out, he's going to have a high DLCO, okay? So DLCO really is fully proportionate to the different alveoli function, okay? And that is what we do, and that is the third of the tests, and that's called the DLCO. Now, what's very important is you could sometimes have what is known as false positive, false high DLCO. So you see, patients who have, let's say, breathing problems, let's say he's obese, he's unable to breathe properly, or he has scoliosis, or let's say a chest wall defect. In any of the situations where he's unable to breathe properly, what happens is, remember, in order to get air within the alveoli, remember the alveoli is within the respiratory zone. And in order to get air within the respiratory zone, you have to take a deep breath in. So a person is going to have some type of defect where he's unable to take a deep breath in, therefore, it's not going to have any type of alveoli exchange, and we might assume that he might have some type of emphysema or some type of other alveolar disease just because he's just not breathing properly. So to differentiate, this is important, to differentiate this from some type of breathing problem, what's important to do is you want to do what is referred to as the alveolar ventilation. Alveolar ventilation basically tells us the ventilation within the alveoli. Now, if the alveolar ventilation comes back low as and equal to the DLCO, that means that the patient just did not breathe improperly, okay? We're having low alveolar ventilation because he didn't breathe properly, therefore we're going to have a high DLCO, okay? And vice versa. If, let's say, his alveolar ventilation is going to be normal, however, there was a problem within the actual alveoli which basically prevented him from actually diffusing oxygen properly, then therefore that tells us that this is that he's breathing properly, and therefore it's some type of emphysema or some type of other alveolar damaging disease. Okay, so that are the pulmonary function tests. Okay, next we're going to be discussing the different diseases, the obstructive diseases. We're going to discuss the restrictive diseases later. Now, the obstructive diseases can really, you could really have three different patients with obstructive diseases. You could have what is known as the asthma patients. You can have the COPD patients. COPD it can be classified into two groups: the chronic bronchitis and the emphysema patients. And the third group of patients is going to be the bronchiectasis patients. Okay. Now, first we're going to talk about the asthma patients. Now, wait, before we talk about asthma patients, let's first summarize the different common denominators that we could be find in all the obstructive diseases, okay? Now, the first thing to find in obstructive diseases, the way you diagnose all obstructive diseases is, like we said before, you're going to have a decreased value in the FEV1 over FVC that's less than 80%. Again, we're going to say less than 80% even though it's a little controversial, okay? That's going to be less than 80%, and that indicates that there's an obstructive disease. Okay, the second thing that we're going to find, let's say if you're going to do a flow volume loop chart, okay, this is a normal chart. In let's say an obstruction disease, what's it going to look like, because it's a disease of the small airway, so it's going to look like this. Okay, that is how it's going to look. Well, more like this, but that is how it's going to look. The right side of the bell is going to be much more prolonged because we have an obstruction within the large airways. Okay. Now, the third thing that we're going to have in the obstructive patients is you have to understand in these patients, because air gets obstructed within their airways, what happens is that the lungs become hyperinflated. Okay, when the lungs become hyperinflated, of course on the X-ray we're going to be seeing hyperinflated lungs. So basically on the X-ray what we're going to see is we're going to find hyperinflated lungs. Because again, remember, in the chronic process what happens is if we have a hard time getting air out of the lungs, so eventually air is going to go and spread out and it's going to expand the lung. And of course, when the lung's going to expand, we're also going to have in all obstructive diseases an increase in the total lung capacity. So that's all obstructive diseases. In addition, we're also going to have increased residual volume. Why residual volume? Because normally in obstructive diseases, because air has a hard time getting through the airways, so of course when we blow out, when we exhale, because air has a hard time moving through it, more air is going to be left over into the lung, and therefore we're going to have an increase in the residual volume. Okay, so those are basically the different common denominators within the obstructive diseases. Now, the first obstructive disease we're going to take right now is going to be the asthma patients. Okay, the asthma patients, first of all, is very important to understand and really to define the asthma patient. Asthma patient is defined as reversible, very, very important, bronchoconstriction. Okay, now, for example, unlike the COPD patients and let's say the bronchiectasis, they're really going to have an irreversible bronchoconstriction. So it's very important to first define what asthma is, okay? And usually the bronchoconstriction is going to be caused by some type of immune mediators. Most commonly, for example, histamine, bradykinin, leukotrienes, and other type of prostaglandins, different type of immune mediators. And of course, when we have immune mediators, when they go and they stimulate the blood vessel, of course this is going to lead to edema. and of course this can lead to obstruction of air, and we're going to have less air moving through the bronchioles, and as a result of this, the patient is going to have a couple of symptoms. The first symptom the patient can have is they're going to have dyspnea. Dyspnea means shortness of breath. Why are they going to have shortness of breath? Because we're bringing less oxygen, obviously, within the lungs. The second thing we're going to have, because we're having immune stimulation over here, the immune system could also activate the different receptors within the smooth muscle, the bronchioles, and of course this could lead to the different types of coughing in the patient. Patient a lot of times have a chronic cough. In addition, patients, what happens is, again, immune mediator could also go activate the smooth muscle, and patients could have types of chest discomfort. Typically, it feels like the patient has very, really tightness within his chest, and other symptoms the patient could have within asthma. They could have wheezing. Okay, now wheezing really is defined as a sound produced when air has a hard time getting through a obstructive airway. Now, normally, wheezing we can have what is known as inspiratory wheezing, and we can have expiratory wheezing. Okay, inspiratory wheezing, this is usually not seen in asthma patients. I'll tell you why. Because normally, when you inspire, normally the air, when it goes into the extrathoracic airways, will go and it will collapse the extrathoracic airways. However, when it moves down to the intrathoracic airways, what happens is because our diaphragm contracts and we're having that negative pressure, so that negative pressure is basically going to go and it's going to open up and it's going to pull open like a vacuum the bronchial airways. So despite that the airways should normally collapse the airways, the negative pressure is going to open the airways, and therefore we usually do not see wheezing during inspiration. However, during expiration, when we go and we exhale, so of course the diaphragm is going to go and relax, and when the diaphragm relaxes, we're going to have a loss of the negative pressures, and we have a loss of negative pressures, the bronchioles will then start to go and get smaller, and of course when we get smaller, that's when we're going to have an obstruction, and of course that's when we're going to hear the wheezing. So wheezing is usually going to be during the expiration. Now understand, obviously, if the asthma patient is going to be a severe asthma patient, then obviously we're going to have an inspiratory wheezing, because despite the negative pressure, the patient's still going to have a very significant obstruction, so we can have inspiratory wheezing as well. Okay, and of course other symptoms that asthma patient can have, obviously, is because of increased sympathetic nervous system. So the patients can have, for example, tachycardia, they can have increased heart rate, they can have tachypnea, they can have increased breathing, and of course they can have diaphoresis. Okay, that is normally the symptoms of an asthma patient. Of course, again, it's always variable depending on if it's a exacerbation or not. But again, we'll discuss the different scenarios now. Okay, so now there are a couple of different scenarios we need to talk about an asthma patient. I think the most important one is really for you guys to understand is really how to deal with and how to manage a patient with a asthma exacerbation. Okay, so an asthma exacerbation, the first thing we have to discuss. Okay, exacerbation really is going to be in the acute setting. Okay, this is an emergency setting. This is in the acute setting. So you could be a paramedic, you could be an EMT, a doctor, whatever it is. Basically, a patient, for whatever reason, again, first of all, let's talk about the different exacerbators that might cause a patient to have an asthma exacerbation. So the things that can cause an asthma exacerbation, number one, are obviously allergies. Different allergies could go and activate the immune system, which could lead to all these immune mediators. It could be different infections could go and cause it, specifically viral infections like to cause asthma exacerbations. We could have different type of, molds and dust can cause it. In addition, reflux can cause it. Reflux can also aggravate asthma exacerbation. It can trigger an asthma exacerbation. And of course, other things, for example, certain types of drugs, aspirin, nasal polyposis. Again, we'll discuss that later, okay? But again, it's most commonly allergies and infection are really going to be the most two common ones that like to cause asthma exacerbation. In addition, also, intense exercise can cause asthma exacerbation, as well as, if a person stays in the pool for a very long time, he could develop an asthma exacerbation. Okay? And of course, we get to the scene, the patient might have all these symptoms, he may not have all these symptoms, he definitely will have the dyspnea, the tightness in his chest, the wheezing possibly, and of course some degree of sympathetic overstimulation. Okay, so how are we going to manage this patient? So the first way we want to manage this patient, the first thing you want to do is when you get on the scene is you have to make sure that the patient is stable, okay? Because that's the most number one priority, is to make sure the patient is stable. Now, how do we understand when a patient is stable? Well, we first have to understand what it means to be unstable, okay? Unstable patients, okay? Unstable patients, again, that's number one. First, you have to make sure the patient is stable, okay? That means taking them out of the unstable. Unstable means any type of respiratory, problems. For example, a person is going to have respiratory distress. Let's say he's going to have use of accessory muscles. Okay, always having intercostal contractions. Okay, any of those situations, that means that his respiratory is really going to be in distress, and of course, that's a bad sign. Also, the patient's going to have cyanosis. If he's cyanotic, he starts to turn blue. If he's having, diminished lung sounds, if he's having, for example, inspiratory wheezing, all of those indications that the patient is going to have some type of respiratory distress, and of course, that means unstable. In addition, patients also with any type of cardiac manifestations. Cardiac manifestations, for example, if a person, due because of this asthma exacerbation, is now going to develop, let's say, angina, chest pain, or he's going to develop some type of palpitations, or let's say some type of arrhythmia like a fibrillation. In all those situations, that means the patient is unstable, and of course CNS as well. A person starts developing seizures, a person starts to go into coma, lose consciousness, alter mental status. All those are examples of patient being unstable, and in those situations, very, very important, you have to make sure that the patient will be properly intubated, or at least watch the patient, because this patient might have to get intubated. Also, another very important thing, depending when you do the ABG, I don't know if you're an EMT, a doctor, whenever the asthma patient goes into you, if the ABG, this is extremely important, if the ABGs are going to be showing a respiratory acidosis, what's going to happen is you're immediately going to go and definitely want to go and try to intubate these patients. You see, normally during the ABG, what happens is that the blood glasses, when they come back, because the patients are going to be tachypnea, they're going to be very fast. Of course, the faster you breathe, the more carbon dioxide you're going to be expelling and throwing out of your lungs, okay? Now, and because you're expelling a lot of carbon dioxide, of course, carbon dioxide actually will go and normally lowers the pH. However, because you're blowing all your carbon dioxide out, you're going to increase the pH. So patients usually are going to be and have on the ABG respiratory alkalosis. However, if the patient is an asthma exacerbation patient and he has a respiratory acidosis on the ABG, so that is a very, very bad sign. That means that the patient is not even exchanging carbon dioxide. It's so severe that he can't even exchange carbon dioxide despite he's having tachypnea and he's breathing fast. Therefore, that's a very severe sign that he's going into respiratory distress. He's going to eventually develop respiratory muscle fatigue, and of course he's going to fully stop using his respiratory muscles, and of course he's going to die. So a patient with an ABG that shows acidosis, you immediately got to think to intubate this patient, okay? So that's step number one. The first thing you want to do is to make sure your patient is going to be stable. Now, once your patient is stable, then you can start the treatment. Now, the treatment for asthma, there are really three things. The first thing you want to do, obviously, is you want to give oxygen. You're going to give them 107% saturated oxygen, typically through a non-rebreather mask, okay? That's the first thing you want to do. Again, you can really do this all simultaneously. The second thing you want to do is you want to give them albuterol, okay? Normally, albuterol is a beta agonist. You see, normally on the bronchioles are normally beta receptors, okay? These beta receptors, of course, when they're stimulated, of course, they'll get active, and when they're stimulated, this is going to lead to bronchial dilation. This will go and dilate the bronchioles. And with dilated bronchioles, air can now flow much easier through the bronchiole, and of course can go and be ventilated through the lungs, okay? So basically what we do is we give albuterol, which stimulates these receptors to go and lead to bronchial dilation, so more air could get into these patients, okay? Now, technically, albuterol could be given in two different things. It could be given in what's known as an MDI, a metered-dose inhaler, or it could be given in a nebulizer. Okay, note over here, an MDI and a nebulizer are equal in efficacy in terms of delivering albuterol. Now, you might want to use a nebulizer over here only because it's more convenient for your patient. Sometimes patients are really in a hard time, doing it themselves. So therefore, it's probably just more convenient to just give them a nebulizer. But technically, just know for the boards that they are going to be equal in efficacy. Okay, that's very, very important. Okay. Now, also in addition, besides for albuterol, some people like to give. And again, I wouldn't really recommend this for the board exam to pick this. But also, there's another receptor on the bronchioles, and that is the muscarinic receptors. Now, normally when muscarinic receptors are stimulated, of course, by acetylcholine, this is going to go in the opposite. This is going to lead to the vasoconstriction of the bronchioles. The bronchoconstriction of the bronchioles. So, really, what do we do over here? If we go and we block these receptors, we go and we give it, let's say, for example, an anticholinergic, then, of course, we go and we do vice versa. We go and we dilate the vessels, of course, allowing air to get into the lungs, okay? But again, understand that anticholinergics really are not the best prime drugs to use, especially in the acute setting, because they usually take some time to really, take action. And albuterol is a very quick-acting drug, so albuterol really is going to be the prime drug used in the asthma exacerbations, okay? And the third thing we got to do, obviously, is we got to give steroids. Now, why are we giving steroids? We're giving steroids because, remember, bottom line, the patients are going to have hyperstimulation of the immune system within the lungs. okay, and they're going to have all these immune mediators. Now, we could try basically, revealing these symptoms and make sure the patient doesn't die by dilating the vessel, dilating the bronchioles to allow more air in, but we're not fixing the problem that there's going to be all of these inflammatory markers over here. So basically, we give the steroids. Typically, we're going to have to give the IV steroids, of course, and this will obviously go and is going to decrease inflammation. Now, you know that steroids also take about, I would say 12 to 14 hours, 12 to 20 hours to work. So of course, you obviously, the second you get these patients and you give them the steroids, you give them albuterol until they're stable, and of course, then you could go and you could tamper with the doses, and you're really going to give them the steroids for about 2 weeks, and that's really when all the inflammation is going to decrease. Okay, and that is how you manage a patient with a asthma exacerbation. Okay, so you give them oxygen albuterol and you're giving them steroids. Okay, now the next thing in the next scenario we're going to deal with the asthma patient is we're going to deal with asthma patient within the actual hospital setting. Okay, or really as a doctor. Okay, now asthma as a doctor setting, basically a asthma patient comes to you normally he usually will come to you complaining that he has, let's say, chronic coughing, or let's say he has, chest discomfort. He might also tell you that he has family, with history of asthma patients, and a lot of other signs that, yes, he definitely may have asthma. Okay, now even if a patient has an asthma exacerbation, and this is a very, 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 very frequently asked question on the board exams. Even if you know a patient has asthma, whether it's all the signs, whatever it is, the first thing you want to do if you suspect that a patient has asthma, let's say he has a chronic cough, etc., you have to do a pulmonary function test. And on the pulmonary function test, it has to show that the patient is going to have a FEV1 over FVC ratio that's under 80%. Okay. Okay. However, and this is the most important part over here, but it gets better when you give a bronchodilator. If you give a bronchodilator, this is going to get better, this is going to improve. You see, normally in these patients, then asthma patients, because they have inflammation here, so we're going to have obstruction, and when we have obstruction, we're going to have a decrease in the FEV1 over FVC ratio that's less than 80%. However, normally, let's say, for example, we give albuterol and it gets better, because it gets to get better, so the FEV1 over FVC is going to get better, it's going to improve when we go and we give a bronchodilator. Okay, that is how you diagnose asthma. Now, in some patients, what happens is when we do the pulmonary function test, it comes back that there is a normal FEV1 over FVC ratio, okay? And that's a little tricky for some students, because a lot of times it really does not show that the patient has asthma on just a random pulmonary function test, okay? So if you still suspect that the patient has, let's say, for example, you go and you get a negative FEV1 FVC ratio, let's say it shows that there's 100%. Therefore, but let's say you still want to suspect the patient has asthma, then you're going to do what is known as the metacholine challenge test, okay? And what a metacholine challenge test basically does is we give this mild bronchoconstrictor. And in an asthma patient, these asthma patients for some reason are very, very sensitive to this bronchoconstrictor. And when you give this metacholine challenge test to them, they're going to have a decrease in FE1 over FVC ratio that's going to be less than 80%, okay? And that is also how you're going to diagnose asthma. For example, not for example, but let's say I would do a methylcholine challenge test in, let's say, a normal person who doesn't have, asthma. Let's say, for example, thank God I don't have asthma. If you do the methylcholine challenge test on me, I won't have any decrease in my FEV1 over FVC ratio, okay? But a person with asthma is going to have that, okay? And that is how you diagnose asthma. Now, once you diagnose asthma, okay, once you get a positive for asthma, what you're going to do is you have to get a very, very, very brief history. You want to see how many attacks this patient is getting. You want to see how severe their attacks is. If they've ever been hospitalized, you want to look for different allergies, different infections that may be, triggering these asthma exacerbations. A brief history is always very, very important, especially in the asthma patients, okay? Now, regarding the treatment for an asthma patient, well, the treatment actually depending on how the patient is going to be classified. Now, asthma, you could have the mild asthmatics, you could have the moderate asthmatics, and of course you could have severe asthmatics, and there's even a stage level which is known as a steroid-dependent asthmatics. Okay? In mild asthmatics, the patient is getting less than 2 attacks a week. Most patients with mild asthma, again, they're typically seen in children. They may be getting an attack, let's say, once or twice every, couple of months, maybe once a year. The asthma attacks usually are not so severe. There are no night symptoms usually with these patients. They're not waking up coughing. They're not waking up with chest discomfort. And basically, you can send these patients home, and you're going to be treating these patients with basically just the albuterol with the MDI, the metered-dose inhaler. And of course, you'll tell them to use the albuterol and the metered-dose inhaler when they need it, okay? Now, regarding the moderate asthmatics means they're typically having more than 2 asthma attacks a week. In addition, these patients also a lot of times develop different type of night symptoms, okay? And the treatment for going to be mild asthmatics is going to be, again, you're going to give them the albuterol plus a metered-dose inhaler, but you're going to add the inhaled steroids, okay? Now, let me just say one thing about the inhaled steroids. The first thing about the inhaled steroids is, again, a lot of times it's a very, very bad taste for the patient's mouth. So you have to give it through what is known as a turbo inhaler. That's the first thing they like to ask on the exam. The second thing you have to know about the steroids is that although it's inhaled steroids, obviously doesn't have the same detrimental effects as regular steroids, it still has its effects if you use them for a chronic long time. That is why in children, the really difference between the mild asthmatics in children we could also use, instead of the inhaled steroids, we could use what is the mast cell stabilizers. Okay, mast cell stabilizers, for example, bromelain, will basically go and stabilize these immune cells, so we don't release so much, histamine, bradykinin, leukotrienes, and prostaglandins to cause the inflammation. So really, the inhaled steroids as well as the mast cell stabilizers are really used as a prevention measure to cause asthma exacerbations. Now, the reasons why we don't use mast cell stabilizers in adult is that studies show that mast cell stabilizers only really have effect in children. An adult has a much severe asthma. No, remember, as asthma goes on, of course, it gets more severe. Again, it can either get better or get worse. So it's one or the other. And usually if an adult still has asthma, it's usually much more severe, and mast cell stabilizers won't work in an adult patient, okay? Now, regarding the severe asthma patients, severe asthma patients is, again, is a moderate asthma patient, you'll be using the night, one more important thing. In addition, anytime a patient has night symptoms, you're going to give the patients the anticholinergics, okay? You're going to give them the anticholinergics. Why? Because, like we said before, the anticholinergics have a long-term effect of a bronchodilator. It has again, it might take longer to work, but it has a much longer effect as typical albuterol. So patients going to have, night symptoms, again, it can be very, very problematic for the patient. He'll be waking up many, many times telling you that he's coughing. He has very, severe, chest discomfort. So what you're going to do is you're either going to give an anticholinergic to these patients if he has night symptoms, or you give a long-term beta agonist. But typically, we like to use the anticholinergics. Okay. Now, regarding the severe asthmatic patients, again, severe asthmatic patients is you'll be treating the patients with the inhaled steroids plus the albuterol plus the MDI, and it still failed to get better. And in those situations, what you're going to do is you're going to add. Of course, you can give all these stuff, but you're also going to be adding long-term beta agonist or a anticholinergic. And of course, these patients are going to take these every day to go and try preventing the asthma exacerbations. Because again, severe asthma exacerbations is these patients do not get better with any of these type of medications. And are often hospitalized. They have ambulances coming to their houses every day. So give them the long-term beta agonist, and plus, if they ever get an exacerbation, give them the inhaled albuterol and see if that helps. Okay. Now, if that still doesn't help, after giving the long-term beta agonist over anticholinergic, that is referred to as the steroid-dependent asthmatics. Okay, and the steroid-dependent asthmatics, just note over here, this is where we're going to be giving the patient the oral steroids. Okay, we're going to give the patient the steroids to basically, every single day, to stop these cells from going and even leading to the asthma exacerbation, to go into the immobilize this patient. And again, obviously, this is our last option because we know how detrimental steroids can be. So if you're going to be treating a patient with the steroids, you obviously have to go in every, really a couple of weeks, go check up on the patient, try lowering his doses. A lot of times we could try lowering the doses. We can give a patient what is referred to as leukotriene inhibitors. Leukotriene inhibitors basically go and block over this. And if we block this, we have less inflammation. So we could try, giving them leukotriene inhibitors that really showed to work. And also, in addition to lower the steroid doses, so they're not going to get so high. But of course, patient really still has to be on the steroids, okay? And of course, again, you really have to monitor these patients, okay? And that is really how you go and you treat a patient with asthma. Okay, now the next thing we're going to talk about is the COPD. Now the COPD, I don't think we have room over here.